ahead in 2021. And a word from our sponsor, it has been mentioned that Clark County Credit Union has been kind enough to be our partner in our effort to educate and update community members regarding the various diseases, remedies, and various health-related issues. We're really thankful for their partnership with them. These are the learning objectives. We will learn about coronavirus infection, its pathogenicity. When one gets infected, how the infected individual or host responds towards the infection. Then we will talk about a little bit of treatment options available and focus mostly on vaccines. There are several vaccines that have been already started flowing in the market, and I have received my first shot a week back. In that context, having the vaccines available where we are now, as a nation, as a community, what are the measures there should have been at the beginning of this pandemic, and that should be followed currently moving forward, and what our life looks like post-pandemic. One thing I will mention at the very onset of my presentation is that I would rather stay on the public health aspect, not going detail on the scientific materials, although I have details about science with references. Please feel free to ask me questions at the end of my seminar regarding scientific issues or related public health issues. I will answer those questions as I can. And also I want to acknowledge the researchers, clinicians, frontline healthcare workers, treating physicians, nurses, EMTs, emergency healthcare workers. Their contribution is immense to fight this pandemic, and also freely available scientific materials as referenced throughout my presentation. So this is the description of plague by Albert Camus. Many of you have read this book. Everybody knows that pestilences have a way of recurring in the world, yet somehow we find it's hard to believe that one that crashed down on our heads from blue sky. There have been as many plagues as wars in the history, yet plagues and wars takes people equally by surprise. And this is also true today. So where we are now. This is very recent data as of yesterday. On January 20th, meaning yesterday, worldwide infection is over 94 million with over 2 million deaths from this pandemic. And the graph above shows the blue line that represents infection in US leading the world, unfortunately. But there is a slimmer of hope if you follow this curve. It's slightly going down, and we want to continue on this downhill trend on this pandemic. And there are other highest infected countries in the world, such as Brazil, India, Russia, and other European countries. So where it all began? It all began about a year back. Actually, today is the anniversary for first detected infection in US. On January 21st, 2020, first US infection was detected. Today is the anniversary day. And what is a coincidence? We are talking about this infection pandemic a year later. So it all began in the Wuhan province in China. On January 9th, a Chinese scientist reported, subsequently it was a mysterious pathogen triggering a disease like pneumonia, and Chinese media coined it as novel coronavirus. Subsequently, Coronavirus Study Group, CSG, the worldwide virus nomenclature group, coined the terminology for this infection, severe acute respiratory syndrome coronavirus, in short, SARS-CoV-2 disease. More popularly, it's known as COVID-19 infection, currently as a pandemic. Have we seen this virus before? Yes. We have seen the family of this virus before. This timeline shows the respiratory acute, severe acute respiratory syndrome, SARS-related coronaviruses. We have seen this in 2003 in Hong Kong as SARS. In Middle East, few years later, 2012, as MERS, Middle East Respiratory Syndrome, and in 2019 as coronavirus disease 2019, current pandemic. So as a humankind or human race, we have seen this infection with us before. But this is the most deadly form of this family of virus infection that ever infected human being. This is a single-stranded enveloped virus with a large genome. It carries very distinct, large club-shaped spikes that radiates out of this viral structure that gave its name as a coronavirus. Kind of give us a crown-like appearances. There has been many mutations, as you may have aware in local newspapers or in popular media or newspapers, occurred in S protein that is involved in setting up the infection in the infected individual. And those one of the earliest mutations, D614G, has been detected since last year. It's not new. Currently, B11.17 is the largest mutant circulating all over the world, and variants of this mutant is N501, H69-V7. These are the most prominent mutation currently circulating worldwide. And it has been estimated that about 2 mutations are occurring on this infection per month. There are many stories. I was reading one of those stories yesterday that in Aberdeen, in UK, one individual got infection, hospitalized, stayed in hospital about 4 weeks for full recovery. Within that period, clinicians have found at least several different mutations in the same individual who was at the hospital being treated for that infection. In that context, mutation in viruses is not unknown. Viruses always do mutate, including the current seasonal influenza virus. It's their strategy, meaning the pathogen strategy, to escape the immune response or evade vaccine-induced immune protection. What those mutations will do is largely unknown at this point, but we will learn them as time passes. But it is suspected that these mutations may increase the pathogenesis and may trigger severity of the disease condition. Also, questions has been raised that if we started seeing these many mutations in S protein, how it relates to the vaccine efficacy or effectiveness, because so far all the vaccines targeted towards the S protein of this infection. And on the right-hand side, this is an electron micrograph that shows a cell type heavily infected with coronavirus. These yellow dots are the coronavirus infecting a particular cell type in our body. That's the purple colored cell type. Let's talk about a little bit of infectivity and mortality of this virus. It's very severe infection for various reasons. One of the primary reasons this virus is so severe in infection and triggering such high mortality is that it jumped species, meaning there is a terminology called zoonosis. It usually occurred in animal. At some time point, it's suspected that in Wuhan province, in the wild animal market, somebody got in contact with a wild animal. And from that point, it started transmitting in human being. So in some ways, we never experienced this specific strain of coronavirus in us. Thus, it's highly transmissible. It increases its vulnerability and infection of the diseases. Recent so-called London mutation may increase the infectivity by 60%, high fatality rate, about 0.65% of the individuals infected, they may die, and R0 value widens variedly, meaning one infected individual, how many others can get infected from that one infected individual, that is defined as R0 value. commonly ranges between 2 to 3 or 3.9. That is pretty high. Fatal disease observed in individuals over 65 years of age. Prevalence of asymptomatic infection is about 45% in the virus detected individuals, but without any clinical symptoms, meaning many of these are asymptomatic patients and they can have about 75% transmissibility. Perhaps that transmissibility may remain longer than 14 days. And that's the most dangerous aspect of this virus infection. Many of these asymptomatic individuals would not feel anything that they are infected or they are carrying infection. Thus, they will perhaps mix freely with other individuals and they can transmit the infection. About 50% of the COVID-19 transmission occurred before one gets sick. Those information has implication in our public health policy formulation. We will get to that point at the very end of my talk. A lot of scientific information in here, but essentially it shows that this virus binds to ACE2 receptor structure in our body. S stands for angiotensin convertase enzyme 2. We all have that receptor structures for different purpose. It is involved in our blood pressure monitoring, cardiac function, etc. These receptors, particularly expressed in our lung cells, nasal epithelial cells, and lining of the blood vessels. Unfortunately, this virus binds to ACE2 receptors, sets up the infection in us, and the skewed expression of the viral receptor or entry associated proteins such as ACE2 receptors in our upper airway may be correlated with enhanced transmissibility. That's the most unfortunate aspect of this infection. And after one gets infection, the virus exits that infected individual via certain structures called lysosome, detailed signs. And when those droplets is caught by someone else, that's the way the spread of infection occurs. And here, those lysosomal structures are shown in here, this green circle laden with those viral particles. This is an electron microscopic structure of the COVID-19 within a cell type. What is the time course of SARS-CoV-2 infection that triggers illnesses? Left-hand side panel, top left panel graph shows incubation period is sometimes rather long. When the onset of symptom begins, that is day 0, maybe 5 days prior to that, or even 10 days prior to that, average is about 5 days, someone really got exposed to the virus infection, then virus infection grows in that individual and nasopharyngeal viral load is the highest around day 6 post onset of the symptoms, about 5 to 6. So within that period, from the onset of symptom, within 72 hours, if we take a nasal swab, there's a highest chance of detection of this infection. Subsequently, the viral load goes down. It takes about 3 weeks, but from day 3 onwards, antibody response begins, and that remains at a peak day 12 onwards. If we can translate this kinetics of virus infection into phases of infection, first, it begins with a viral phase, meaning viral replication is taking place at a high level. Then comes so-called cytokine storm, where inflammatory cytokine responses to the virus infection takes place in the infected individual, the host. Subsequently, there may be a coagulation phase where clotting cascade defects or clotting defects can be observed in certain individuals, and it ends with late hyperinflammatory phase that may extend up to day 28. So to sum up these two graphs, median incubation period is about 5 days. Peak transmissibility is half a day before the symptoms detected. Onset of fever begins. The clinical disease course and can last up to 3 weeks. Median duration of the fever is about 4 days. Peak nasopharyngeal viral load can be detected from day 3 to day 5. Those 3 stages, again, clinically, asymptomatic stage. Stage 1, initial 1 to 2 days. Stage 2, upper airway responses, next few days. Subsequently, this is the most dangerous stage of this infection: hypoxia, lack of oxygen, breathlessness. That leads to the intubation, ICU type of treatment requirement. And ground glass infiltrates in the lung, meaning lung at that point became opaque, loses ability for oxygen carrying, and that leads to the progression of ARDS, adverse respiratory disease syndrome. That is the most severe form of the disease. About 20% of the infected patients will progress to stage 3 of the disease and will develop pulmonary complications with very severe disease condition. And down below, this is the lung of the of an infected individual infiltrated with these purple cell structures, meaning white blood cells. Usually we should not have that many white blood cells in our lung, but in an infected individual, infection resides primarily in the lung, thus many white blood cells rushes in there in response to the infection, and ultimately they will be orchestrating immunopathology, releasing high degree of inflammatory cytokine to combat the infection. And this is the ground glass opacities in the infected individual's lung and the clotting cascade defects that has been observed in the toes. Same information is shown a little in expanded view, what happens in the lung, and down below here is a 3D model of CT scan of a lung of a 59-year-old individual, unfortunately, who died at George Washington Hospital. And this is how a severely infected individual's lung looks like. At that point, that individual lost his capacity to breathe, depended on intubation, mechanical ventilation, but ultimately lost the battle. So what happens really in the infected individual's lung? Inflammation, that's the take-home message. Release of lots of inflammatory cytokines, such as interleukin-1 beta, interleukin-6, interferon gamma, TNF alpha. These are immunological medical jargons. We all have the ability to release these molecules when we fight infection, but unfortunately in this infection, a huge amount of these inflammatory cytokines are released, and they are located particularly inside the lung and triggers the immunopathology that leads to the damage of the lung tissues, limits the oxygen exchange capacity in the lung, and the lung at that point will be filled with lots of mucus that may trigger secondary infection of the lung. Who are the most vulnerable people due to infection? Unfortunately, the older people. There are many graphs, but take-home message is, as we get older, we lose our ability to mount immune responses against any infection. That is also particularly true for this infection. And on the top right-hand panel shows, with increase in age, more likely to suffer severe complications with coronavirus. And it goes to about 8 to 13 times higher compared to 30 to 39 age group individuals in terms of severity of the complication. And also it triggers higher percentages of death in the elderly population. To summarize the clinical presentation that I have gave you a glimpse of the disease, it attacks males, unfortunately, with a male predominance over 50 years of age with underlying comorbidities such as obesity, hypertension, cardiovascular diseases, elevated lipids, diabetes, chronic respiratory disease, cancer, and renal diseases. What it triggers? At the very onset of the illness, it includes fever, cough, fatigue, and myalgia. Severe cases, more frequently dyspnea, acute respiratory distress syndrome, ARDS, that's the most severe phase of the disease. In many individuals, leukocytosis, meaning killing of the white blood cells. In this context, I would like to mention that white blood cells are the sentinel to fight any infection in our body, including this infection. But unfortunately, in this infection, white blood cells themselves gets killed due to the infection. That triggers lymphopenia, lowering of the lymphocyte counts. Many of the inflammatory markers in the plasma goes up, such as LDH, D-dimer, C-reactive protein. Pro-inflammatory cytokine release gets exacerbated, markedly higher in severe cases than those in moderate cases, suggesting the cytokine storm may be associated with disease severity. One cytokine particularly been implicated in the disease severity, such as interferon group of cytokine, interferon alpha and beta. Interferons are the cytokines that are released to defeat, to combat any virus infection, including COVID-19. And in children and some of the individuals who suffer severe disease consequences due to COVID-19, it has been observed that they are not releasing adequate interferon alpha or interferon beta, or they have anti-interferon antibody already circulating in their system. Estimated incubation period, up to 14 days from the time of exposure, median is 4 to 5 days. So the spectrum of illness can range from asymptomatic infection to severe pneumonia with respiratory distress syndrome and unfortunately death. They fancied themselves free. No one will ever be free so long as there are pestilences. Again, description of plague, Albert Camus. So how do we detect these pestilences? Current one is the COVID-19. Let's talk about the detection. There are many detections developed around 3 to 4 months into the infection, but they were widely available halfway through last year and through the end of last year. 3 most important type of detection tools that I will describe now: RNA-based detection through polymerase chain reaction that detects early and with very specificity, and it's also used for contact tracing, so-called RT-PCR type of detection test. Takes about 24 hours to get the results, but can be gotten earlier. Other type of test detects antibody. One generates antibody once the infection sets in, at least 5 days after the infection. Within 3 to 5 days, more so a 5-day time frame, one will generate IgM class of antibody. At that point, if we take a blood sample, send it to the lab, we can detect IgM class of antibody. Subsequently, there will be also IgG class of antibody circulating in that individual. So at a later phase of infection, we can use antibody detection, enzyme-linked immunosorbent assay, that's the name of the test, ELISA test, to determine infection and antibody response. Very recently, antigen test has been developed for rapid detection of the virus. It has some inbuilt flaws, can trigger up to 15% of false positive results, but this rapid antigen testing is dependent on immunofluorescence-based lateral flow technology, a particular scientific technology that can be used very quickly. Within 15 minutes, one can have the results that whether that individual is carrying infection or not. These type of tests can be used at the airport, and people are trying to include these type of tests at the airport, at the game, different ballparks and game venues, or in our town, maybe for different shows. These type of tests can be administered at the entry point, and within 15 minutes, one will know that whether that individual is carrying infection or infected or not. Some of the names, Sherlock Holmes test, or this is developed, I believe, at MIT in US, and follow the test, its counterpart in India using CRISPR-Cas9 technology. By the way, this is the technology that won the Nobel Prize for 2020 last year to Jennifer Gounder for developing this technology for other purpose, genetic testing and gene therapy aspect. But currently, this CRISPR-Cas9 technology also being used for detection of COVID-19. Now I'll spend a few minutes on the treatment aspect of this infection. Well, I will not go into the detail, but what I want to give you information that there are no standardized treatment available yet that has been approved by FDA. These are all emergency use authorization treatment options. Panel of physicians, statistician experts developed somewhat treatment guidelines for COVID-19. They can be controversial at some time point, but most respected and trusted sources are British Medical Journal, Mayo Clinic, Johns Hopkins, following this best practices for COVID-19 treatment. And all these informations are freely available. And these are the websites where one can log in to find the treatment options. There are certain categories of these drugs. Many of the drugs that were available for other purposes, such as oseltamivir or Tamiflu, that has been used to treat influenza virus infection, that has been tried to treat a COVID-19 patient. So these are called repurposed drugs that has been developed for other purposes, but clinicians are trying to find whether these drugs will provide some type of relief in COVID-19 infected individuals. There are many, some of notable ones. Discredited hydroxychloroquine use earlier last year subsequently found that it really does not help in controlling the infection. But azithromycin is very useful to treat co-infection in the lung, particularly bacterial infection. Interferon treatment, that is very helpful in the early stage of infection. IL-6 inhibitor drug, antibody drugs such as tocilizumab or IL-1, interleukin-1 receptor targeting antibody anakinra, these are the very important drug in fighting severe COVID-19 infection. Many other investigational drugs that came into the limelight, such as remdesivir, antiviral drug, that is at this point given at a hospital setup, intravenous injection, very costly. Not many even can access that drug, but that has some usefulness in the early on in the treatment of COVID-19 patients. Another molecule, convalescent plasma, such as anti-SARS-CoV-2 antibody, meaning the individuals who got infection, they recovered the infection, and if one draws the blood sample from those individuals, separates the plasma, plasma carries the antibody. Those antibodies can be successfully used to treat early on, within 72 hours of the infection, to treat COVID-19 patient population. And I believe today in Las Vegas Review Journal reported that some of the monoclonal antibody that are commercially available following this convalescent plasma hypothesis, such as from Eli Lilly or Regeneron, they are conducting clinical trials to preemptive injection of those antibody, meaning if someone thinks that he or she might get into a situation where they can get exposed to the infection, they can take those antibodies prior to getting exposed to the infection so that they remain protected for about a month. It's hoped that these two companies, Eli Lilly and Regeneron, will file for emergency use authorization to FDA for that type of usage of those two antibodies. Other than that, concomitant drugs such as RAS inhibitors, ACE inhibitors, non-steroidal anti-inflammatory drug ibuprofen is very useful to suppress the little pain, fatigue, headache, etc. early in the infection. Also, steroids have been found, dexamethasone have been found to really helpful to subdue inflammation in the infected individuals. But none of these treatments have been approved as a regular treatment options by FDA. These are all emergency use authorization. So it depends on the specific clinicians or group of practitioners who follows some treatment guidelines in combination with those few treatment options that I have mentioned. I'll talk a little bit about convalescent plasma or monoclonal antibody treatment because this is specific treatment against this infection. Particularly, Eli Lilly and Regeneron, these two companies have developed monoclonal antibody specific for SARS-CoV-2 spike protein specific antibody. These are high titer neutralizing antibody, and these antibody shows promising results in neutralizing viral load in patient population with moderate to severe infection if administered early on. That's the key point here. Not every individual does have the access to this antibody treatment because these are very costly and these only can be given at the hospital setup. These antibody treatment may also be beneficial for prevention of infection in healthcare workers of family members of recently diagnosed patient population. And as I was mentioned previously, that these two companies have started thinking that why not we apply for authorization to use these antibody treatments prior to getting to infection, meaning these antibodies last about a month in our circulation. So if I take these antibody shots, most likely I will have a protection inbuilt in me for next 1 month. So far, we have talked about a little bit of pathophysiology, immune responses or immunopathology, detection, and treatment options for this infection. Now let's take a look at the vaccine scenario. What's happening in terms of vaccination, immunization? This is another description of plague in Athens as early as 430 BC. And this is one of my favorite quotes. The most important element of this quote is in the last paragraph. And had now no fear for themselves, for the same man was never attacked twice, never at least fatally. Meaning, if someone gets infected and recovers from the infection, then they are protected against the infection. That's natural immune protection. Can we take that idea and develop vaccine against various infections, including COVID-19? Yes, that was the case. So this is the vaccine development approaches that scientists take to develop vaccines against any infection. It takes about 10 years. Preclinical studies in the lab, then phase 1, phase 2, and phase 3 clinical trials. Then scientists will have to submit the application to the regulators such as FDA. After all those things, a vaccine has been released, is usually released in the market, and it takes at least 10 years. And there are many failures in vaccine development approaches. But for COVID-19, scientists worldwide worked tirelessly, almost round the clock, 24 hours for last 1 year. And they came up with vaccines, successful vaccines against COVID-19. We should all celebrate that aspect of science. What are the different types of COVID-19 specific vaccines? There are many. Whole virus specific inactivated virus, weakened virus, viral vector that with the insert of COVID-19 DNAs and RNAs, nucleic acid specific RNA vaccines that are currently in the market, also protein-based vaccines. And these are the numbers of many vaccine candidates that were in development or are in development. At this point, there are at least 140 different vaccine candidates being developed worldwide. This has been a tremendous collaboration worldwide in science and in clinics to develop vaccine against COVID-19 on a war footing basis. Success stories are many. I will highlight few of those success stories. Moderna and Pfizer-BioNTech vaccines are the leading vaccine candidates in US. These are best in mRNA formulation, in mRNA in lipid formulation. This mRNA, messenger RNA, genetic material out of COVID-19 spike protein sequence formulated in 4 different types of lipids and being used as a vaccine formulation. There are other vaccine formulations such as adenoviral vector containing DNA from spike protein pursued by AstraZeneca. That also received approvals in Europe and other countries in the world. DNA vaccine by Ionovio and protein-based vaccine should be coming up very shortly from Novavax or Pitcovac, University of Pittsburgh's effort. Whereas the killed virus vaccine formulation have been approved by Indian Council of Medical Research in India. So Covaxin, AstraZeneca's vaccine formulation, some Chinese vaccine formulations, Pfizer's vaccine, Pfizer-BioNTech and Moderna vaccines are the current leading vaccine formulations that are being used to defeat this pandemic. How this works, this is detailed science, but essentially be it a DNA or RNA vaccine, when it's injected into the patient's arm, that generates spike protein specific antibodies and T cell responses occurs in our body, and they remain in our body in circulation for a long period of time, so that in cases of future infection or exposure, that individual is protected against that infection. These are the leading vaccine candidates: Pfizer, BioNTech, Moderna, and AstraZeneca's vaccine formulation. And once again, these are the ways the vaccines will trigger immune responses. Essentially, these vaccines generate high titer antibody responses and T lymphocyte responses in the vaccinated individuals. Both Pfizer and Moderna vaccinations are given 2 shots. Pfizer vaccine 21 days apart, Moderna 28 days apart, whereas AstraZeneca's vaccine formulation will also require 2 shots 28 days apart. There are differences in the composition of these vaccines and how they should be preserved. Pfizer vaccine required to be preserved at very low temperature, -70, whereas Moderna and AstraZeneca vaccine formulation can be kept at 4 to 6 degrees. So there are subtle differences in this formulation of these vaccines, how they are developed, how they should be preserved, and when they will be given to an individual. But one should take the same vaccines twice if that is required. But all these vaccines trigger very high degree of immune protections at the level of 70 to 90% of the protection. That's a very high immune protection through vaccination. I'm pretty much at the end of my talk. After this, I will deliberate on a little bit of public health aspect and policy aspect and moving forward where we are now and what we expect with the vaccines available in the market. Before I move into that area, let me re-emphasize that masks prevent transmission and infection. Actually, if we all wore masks from the very beginning of this infection since last year, probably we could cut down the death by 50%. Masks prevent transmission about 70% level. There are differences between the efficacy of transmission, efficacy of prevention of transmission. Most effectives are fitted in 95 mask or KN95 mask, followed by surgical masks, polycotton combo mask, or polypropylene masks. Bandanas doesn't protect that much. That is shown in this graph. And this is another graph that's droplet transmission through those masks. Do not need to go into detail, but this is the take-home message that masks do prevent transmission, and we need to keep wearing masks even with arrival of the vaccines. Little bit of ethics in COVID-19 patient treatment options. Collectively, as a society, we have not faced these type of challenges before. Many of these aspects, particularly ethical aspects of treatment, has been unearthed in the face of COVID-19 infection, meaning when do we make the triage decision? Who gets to get admitted to ICU when there is a shortage of beds? Who gets the ventilators? And who gets the remdesivir? Everybody is not so fortunate so that upon their infection, they will be taken to the highest level of care and given a shot of remdesivir with Regeneron's antibody treatment that we have seen last year. Many of common people, when they get the vaccine, when they get infection, when they needed to be hospitalized, they cannot find a bed at their hospital. So those are the ethical questions we collectively have to come to and develop an answer, develop a guideline so that in a trying time, there is a guideline that can be followed universally throughout the country. There has been also ideas about challenge clinical trial in the context of vaccine development efforts, meaning in UK, certain individuals thought that the best efficacy can be shown that if I receive the immunization, then deliberately challenge myself, meaning inject myself with the infecting pathogen such as COVID-19 virus, that will straight away tell whether I am protected or not. That is called challenge clinical trial, but there is ethical aspect of that. Whether that should be authorized or not, that has been heavily debated. Mitigation of health inequities, priority in vaccination. Who gets the priority? Vaccine distribution and vaccination strategy for the marginal groups who are the vulnerable population for this infection and who are dying disproportionately due to this infection. Finally, vaccines on self doesn't save lives, whereas vaccination does. With all those information, this is where we are now in terms of infection, death, and vaccination in US. This is this morning's data. About over 24 million total cases, over 400,000 dead Americans, current new infection over 3,500, 35 million, almost 36 million vaccine doses distributed. Only half of them have been administered. And these are the number by brand. Pfizer-BioNTech vaccines, about 7 million. Moderna, 5 million. Highest doses administered in Alaska, West Virginia, about 1.65, 1.44%. In those contexts, Nevada vaccination is again means like other aspects, 0.54% with only 102,000, almost 103,000 shots given to the Nevadans. So this is the data, and data doesn't lie. This is what we are at now, even with the arrival of the vaccines. Nevada specific information. Governor has expanded group eligibility for vaccination in Nevada. This is data as of information as of January 18th, along with the healthcare workers who were the tier 1, people over 70-year-old and over, public safety and security individuals, frontline community support individuals. They are getting the vaccines as a priority group 1A. And we should all mask up, back up, and wash up. That should remain our motto for major part of this year. We should help our seniors to get vaccinated, make a plan to get our own vaccination and be ready when our turn comes in. All these information can be found if you log into these websites. And when someone gets vaccinated, they are asked to download this VSAP app. It's a CDC's app, Centers for Disease Control's app, that tracks the vaccination induced if there are any adverse reaction for next several days out from that individual, and goes to a central database without any personal identifying information to track vaccine-induced any adverse reaction, if there are any. So vaccines conquered many diseases in our history, such as diphtheria, whooping cough, and measles, introduced in 1942, 57, or 68. And today, these are the numbers. Some of these infections are a little bit on upswing, but there are reasons for that. We can do the same thing, achieve the same thing with COVID-19 vaccination. So we have learned much through this national and international tragedy. We have learned that infection-induced antibody responses lasts over 6 months in recovered patients. In that context, vaccine clinical trial told us that vaccine-induced antibody in the clinical trial individuals lasts about at least 3 months. Up to that point, it has been tracked, but I suspect or imagine that it will last more than 3 months, up to a year almost, 6 months to 9 months easily. Pre-existing immunity to coronaviruses, because common cold viruses are also family of coronaviruses. We all get exposed to common cold viruses. We get influenza shots annually. So we have some degree of pre-existing immunity to protect us against severe COVID-19. There has been reports of non-specific immunity from BCG vaccines that are found in India. People are trying to understand why infection is not so rampant in India and not so lethal in India. There are many reasons for that. One suspicion is that Is it due to mass BCG vaccination administered in Indian population? Early testing, quick results, tracing, quarantine will determine the fate of this pandemic moving forward, which will break the chain of virus transmission by physical distancing, mask wearing that blocks 70% of the transmission, and if required, facility closure. We need a better comprehensive tests, treatment, and vaccination guideline universally applied. We already have effective vaccines from Pfizer, Moderna, and AstraZeneca. Many will follow. There are monoclonal antibody treatments available from Eli Lilly, Regeneron. That would save someone's life if someone is severely infected and given those antibody treatments very early on in the infection. But we need to vaccinate enough people to trigger community or so-called herd immunity. You have heard this concept mispronounced, but ideally community or herd immunity refers to if majority of the individuals in a community, around 70%, 75% or above, are immunized due to natural infection or vaccination, then they will not contact the infection because they are protected. When they are not infected, they cannot transmit the infection in the rest of the individuals in the community who cannot be vaccinated due to various reasons. That's the concept of herd immunity. But to generate herd immunity, we need to immunize about 70, 75% population in our society, which is a daunting task. Thus, a central and uniform public policy, health policy, should help us moving forward. And there are many unknowns, long-term side effects, mental health impact of the frontline healthcare workers who are fighting tirelessly for the last 1 year, how the new variants, mutants will impact the infection in terms of transmission of the disease severity, and vaccine protection. Will new variants be protected against, will vaccine protect us against these new variants? Early data suggests that yes, they will, but we need to have further understanding in that aspect. To what extent vaccine will protect or prevent most severe cases, it's not known at this point. Stopping transmission, that is largely unknown. Vaccination will prevent infection in the vaccinated individual, but will it stop transmission? Meaning, vaccinated individual can still catch the infection at a subclinical level. They will not be sick, but can they still transmit the subclinical infection to another uninfected individual? That question is still unanswered. Stop of spreading the infection through vaccination. How the vaccinations will work in different subgroups, such as elderly population, children, and pregnant women, longevity or effectiveness of the vaccines beyond 6 months, long-term side effects, will there be any due to vaccination? Most importantly, vaccine confidence or hesitancy. We already start seeing that a large number of individuals, even in healthcare workers, they're adopting the approach, wait and see. Let's wait. Let's see if there are any, whether there are any vaccine-related adverse reactions in the vaccinated individuals, then I will get my shot, although they're eligible to receive the shot. We have to break that barrier. We have to trigger the confidence, break the hesitancy through conversation, through science, that vaccination will protect us, not only us, but to our family members, to the elderly, to the vulnerable in the society. We have to have that candid conversation. Finally, will COVID-19 remain as a community-based infection? The way I see years to come, COVID-19 may remain as a community-based infection. It would not vanish up overnight, even though there are many vaccines available, there are better treatment options available. If so, do we need to get vaccinated every year like seasonal flu? Most likely that's the way it would be, but we will wait to have that answer from the experts. Finally, a futuristic thought. Will there be a universal or combined vaccine that covers coronaviruses influenza, and also COVID-19, current COVID-19 infection. Perhaps that will be that way, and early work has already been started in different labs in the world, utilizing the mRNA platform that is very easy to do. Finally, will vaccine give us our old life back? This is $1 million question. No one has the correct answer. But a vaccine on its own will not end the pandemic. That's the scientific hard truth. We still need to continue surveillance, testing, isolating, tracing, quarantining, contact tracing, and effective caring for the infected individuals. As I mentioned in previous slide, it may remain as a community-based infection for few years. So engaging communities and encouraging individuals to be careful, and we should act together. Because if we act together, wearing masks, social or physical distancing, hand washing, getting the shots, then together we can improve our collective health from getting COVID-19. Overall, states, but unfortunately, states are increasingly diverging from CDC guidance and from each other. That brings to the focus point that there has to be a uniform, universal, nationwide guideline that dictates access to the test, treatment, vaccination. That will help us back to the normalcy, but greatly will depend on where one lives. Meaning, many areas in the country, proper treatment, detection, quarantining, physical distancing, and also vaccination are not equally available compared to many other areas in the country. That's the health disparity that happens always in the context of many other diseases. And it shows the deep gap in that context, in the context of COVID-19 pandemic. But I am hopeful. What gives me hope is that tremendous scientific and clinical advances collectively that we made in last 1 year. Dedicated scientists, clinicians, and frontline workers that brought the improved tests, contact tracing, isolation, quarantining approaches, comprehensive public health policy and overall approaches in the handling of this pandemic. What's necessary now is national and international collaboration that already exists, but it needs to be more emphasized in coming up with public health policy, treatment guidelines, vaccine development and deployment, and vaccination, meaning vaccines on the shelf doesn't protect an individual. Vaccines needed to be deployed and administered. Public awareness in education and infection prevention and vaccination, policies to mitigate social and economic disparity that exists in this infection, triggering mortality in certain ethnic groups. Thus, we need a national pandemic testing that has been declared, I believe as of today, by current administration, which is known as National Pandemic Testing Board and COVID-19 Health Equity Task Force, just announced today. Commitment to investment and structural changes in public health system is urgently needed, meaning how do we approach a pandemic? What are the barriers that we can create preemptively, thinking of future pandemic that will determine our success and moving forward in 2021. These are the local vaccine updates. I want to mention here that Roseman Medical Group is not administering vaccine at this time, but Roseman University is offering vaccine clinics, and the information can be found at this website or calling this number. Other vaccine-related information can be found as Southern Nevada healthdistrict.org. That concludes my talk with you. Thanks for attending, and I will try to entertain the questions that you may have for me. Thank you very much.
Thank you, Dr. Mandal. Excellent presentation. Real quick, we have 4 questions in the chat. Before we go to those questions, I'd like to give Craig Fraley, if Craig is still there. There he is.
Yes, hi.
a minute to say hello before we move into the questions. Go ahead, Craig.
I think it's a great talk. Thank you, Doctor. Everybody know Clark County Credit Union is very proud to be a sponsor for Roseman's Neighborhood Health Series. And we've been providing regular banking service since 1951, which makes us one of Southern Nevada's oldest businesses. So if you ever need any banking help, you can reach us at ccculv.org. And unlike a traditional bank, which is for-profit and owned by shareholders, we are not-for-profit and we are owned by our members, which means at the end of the year, we give all of our profits back to our members. Since 2001, our members have received over $68 million back in their accounts. And I believe tomorrow's the 22nd, there's going to be a deposit in our members' accounts tomorrow for last year's bonus dividend. So thank you again for allowing us to be a sponsor for this. It was a fantastic talk. And back to you guys. Have a wonderful rest of your presentation.
Thank you.
Thank you very much, Craig. Okay, Dr. Mandal, are you ready for a couple questions?
I'm ready.
Okay. All right, starting with the first, is the coagulation phase that you mentioned earlier common in coronavirus infections, or is it unique to COVID-19?
That's a good question. Not much known about this coagulation phase. Definitely it has been observed in certain COVID-19 infected patient population, not in all patients. But to answer your question specific, coagulation defect has been observed in the context of other viral infection, such as dengue virus infection. In dengue virus infection, there is a defect in clotting cascade, platelet mediated clotting cascade defect that has been observed in dengue virus infection. In current COVID-19 infection, certain individuals develop really high level of clotting cascade defects, coagulation defects. Very surprisingly, certain blood group subjects, such as O blood group, Rhd positive O blood group individuals are most protected against coagulation defects due to COVID-19 infection. Why it is so is not at all understood, not clearly understood, but there are some molecular mechanisms related to the H2 receptor renin-angiotensin pathway to the coagulation cascade. That's one of the most very critical, not very well understood interaction physiologically, but the answer lies there. But in short, coagulation phase that has been observed in COVID-19 infected patient population, in certain patient population that has been observed in other virus infection, such as dengue virus infection.
Great, thank you. Okay, how long does natural immunity last after infection?
That's a great question, Duane. I hope that you are referring natural immunity in the context of someone got infected, recovered from the infection, and how long their immunity or immune responses lasting to prevent future infection. Clinical data available so far tracked those individuals about 6 months, I would say 6 through 9 months, more so of 6 months after they recovered from the initial infection. They remain protected, but very recent information data from UK came in. I think that's a clinical retrospective data analysis called SIREN, S-I-R-E-N, clinical retrospective data analysis. You can look at that. I can send you that paper if you're interested. I have that copy. About 1.4% or around 1% of the individual, they tracked 43,000 individuals, if I'm not too wrong, or could be 23, one of those numbers, large number of individuals who got naturally infected, recovered from the infection, then they have been tracked for last 6 months. It has been observed that only about 1.4% of those infected recovered individuals contacted the infection once again. But contacting the infection is not synonymous with getting sick. And majority of those again contacted infection, they did not develop the disease condition, not at least at the moderate to severe disease level. So taking a cue from that clinical retrospective data analysis, we can say that natural immunity, meaning immune responses that are generated after natural infection, that definitely lasts 6 months through 9 months after the infection. It has been tracked up to that point at this point, but as days goes by, months goes by, maybe at the end of this year, we will be surprised to see that, yeah, those immune responses or memory B lymphocytes, memory T lymphocytes that have been generated after the infection and recovery is still found in those individuals at the end of second year after the infection. And I am very hopeful that they will be living in our body and last at least around 2 years, because there has been some clues, another clues from another set of clinical observation very early on last year, around March through April, in I think in around San Francisco, in one of the counties in San Francisco, Sonoma County most likely, clinicians found cross-reactive T lymphocytes from previous SARS infection. So in 2012, some of the patients who infected with SARS, the clinician preserved their blood samples. So they took out those white blood cells out of those preserved blood samples, and then they reacted with the current infection with those white blood cells. They found that those white blood cells still can identify the current infection. So that's the cross-reactivity. But they went back to those individuals and isolated some blood samples and white blood cells from those individuals, and they found that they still carry some white blood cells in their circulations. They can recognize or detect current infections. Will that be protective? That's a separate question. But I hope that infection-induced B cells and T cells in the infected individuals will last for at least a couple of years, and that should be mimicked by vaccination also.
Great, thank you. A few more questions coming in. Typically, viral mutations result in less infectious, less lethal forms of a virus. Although the recent reports indicate the newly discovered mutants are more infectious, do you think that in general, COVID-19 mutants will follow the more typical, less infectious route?
Thanks, Dr. Kaufman. I wish I could answer you yeah or nay, one way or the other. Yes. So you raised a very important aspect of mutation in virus infection. Viruses do mutate, including the current influenza virus infection and all the virus infection. Why they do mutate? Because viruses are essentially parasites, inert particles. They don't have a life if they are left alone in the nature, or somewhere they do not have a life system. So they gain their life once they get inside our body and they replicate and cause the infection. At the same time, the host who gets the infection with any virus, they also trigger immune responses. So immune responses towards that infection. So there is always a tug of war between infection and the host's immune response. So to mitigate the host's immune responses or defeat host's immune responses, viruses do mutate. Do mutate in nature, do mutate inside the patient's body as they are setting up the infection. Question is whether these newly discovered mutants that has been observed in London variants, South African variant, Australian, or those variants are also present in US, all over the country, whether they will be more infective or they will be more subdued. It's mostly unanswered at this point, but certain virologists in UK and in US are in the opinion that H69V70, that B117 mutant or variant, could be 60% more infective in coming months. But these are all predictions or modeling. Some early experiments in the lab setup, in the cell culture setup, has demonstrated their increased infectivity in the cell types in a lab setup. But in a lab setup, what happens, not necessarily that will be or can be replicated in our system. hope that is not the case, but it's largely unanswered question. But there are some thoughts out there, scientific thoughts, that some of those mutations could trigger 60% more infection in coming days.
Great, thank you. Okay, is there any data on whether any of the vaccines are safe for pregnant patients?
Great question. It's so funny. So I have my family back in India. I got a call this morning from my niece in India. She has a 2-year-old, she's still breastfeeding, she's a nurse. She asked me, can I get the vaccine since I'm still breastfeeding? So I explained the scenario. So there, straight away answered, there is no clear guideline from CDC or ACIP because of the fact that none of these vaccines have been clinically trialed in that patient population or in the subjects, pregnant women or breastfeeding women, or individuals below 16-year-old, meaning in children. In absence of that clinical trial, one cannot scientifically say or policy-wise come up with a guideline that it can be used. But at the same time, there are debates going on. Then after that question from my niece, I started looking, I explained the situation. So what are the danger of getting a vaccine in a pregnant woman or a mom who is lactating? There has been instances for other vaccines, a live attenuated vaccine can cause a disease in a pregnant woman because pregnancy triggers immune suppression in that woman just to carry the child to the full term. That happens in our body regular basis. As soon as childbirth occurs, the woman becomes immune sufficient. But when someone is immune suppressed due to carry a pregnancy or to maintain the pregnancy, at the same time, that immunosuppressive condition may trigger infection with a live attenuated vaccine. Now, Pfizer vaccine is a mRNA formulation. Moderna formulation is a mRNA formulation. There should not be such a risk of triggering infection due to those vaccine formulation in a pregnant woman. Although scientifically it will be considered safe, but in absence of a guideline, it should be the call of the OBGYN or the treating physician who should make that call and the confidence level of the vaccine recipient, whether they want to take the vaccine or not. But technically, there should not be any problem or any safety issue in those individuals. Whether they will trigger the same level of immune responses because they are a little bit of immune suppressed, that's a separate question. But mRNA or protein vaccines should not be prohibited in a pregnant woman or a lactating mom. But that story could be slightly different for an adenoviral vector-mediated vaccine formulation such as AstraZeneca's formulation. That's a replication-deficient adenoviral vector carrying a DNA from spike protein of COVID-19. Now, most of us are carrier of adenovirus, but this adenovirus came from a chimpanzee. This is a chimp-specific adenovirus. Whether that adenovirus will still replicate and do something harmful, it's not known. Because it's not known, it's a safe bet not to give adenoviral vector-mediated vaccine to a pregnant woman or a lactating mom. But other than that, protein vaccine or straightforward mRNA vaccines should be safe to be given to such individuals.
Okay, thank you. Here's a complicated one. Ready?
It's a complicated one. It's complicated simply because scientists and clinicians simply have not studied that. They have not included, because all these vaccines, we have to remember, they received emergency use authorization. They did not follow the normal track of vaccine development, authorization, etc. So when things were developing at a breakneck speed, at a rapid speed, simply there were not time to include those individuals in the clinical trial setup. That's all. But those clinical trials are underway in children, in some of those patient populations. Information will come out in next few months.
Okay, thank you, Dr. Mandal. One last question for you.
Yes.
Will there be a reduced number of vaccines in a couple of years when long-term immunity is determined by population data experience? In other diseases, CD8 T cells provide very long periods of immunity up to 30 years, while antibodies typically do not last as long. COVID vaccines generally produce antibodies and CD4 helper cells. Vaccines are producing a wide range of CD8, and so far Pfizer's vaccine produces the highest level of CD8 T cells. Question is in the chat.
That's a fantastic question. It's a fantastic commentary. Yes, this is the area I kind of dwell, because I have worked on how to trigger CD8 T cell cytotoxic T lymphocyte responses against a viral vaccine at the University of Michigan for many years. That is my area of research expertise. But let me get to the point. Yes, some of the infection-induced immune responses or vaccine-induced immune responses have been tracked for means triggering memory B cells and memory T cells that have been tracked over 30 years or lifelong in an individual after they received the immunization or natural infection, such as pox virus vaccine, pox virus infection. That is true. But it varies from infection to infection, individual to individuals, and vaccine to vaccine, meaning 30-year-long detection of CD8 positive T cell in pox virus or any other viral infection, or those infection-specific vaccines may not necessarily be replicated with current COVID-19 infection and COVID-19 vaccines. We hope so. At least current COVID-19 vaccines trigger memory lymphocyte responses in T and B cell compartment for a decade at least, for at least several years minimally. But we have to wait to see. Yes, some of the current COVID-19 vaccine formulations, such as Pfizer's vaccine formulation and particularly AstraZeneca's formulation, because it's a replication deficient adenoviral vector mediated vaccination, that are known to trigger T cell responses, particularly CD8 T cell responses, along with robust antibody responses. So there are differences in terms of immunity or immune repertoire generated due to individual vaccination. It's a formulation-specific immune responses. But all the vaccines will be generating high degree of antibody responses, and antibodies are the first protective immune molecule to neutralize, bind to any viral infection, including COVID-19, and neutralize them before they can get inside the cell, start replicating. Will there be any reduced number of vaccine formulations in the community? That's hard to tell at this point, because reduction in the number of vaccines, available vaccines in the market, will be largely determined by the commercial interests by the vaccine manufacturers. But at the same time, many philanthropic organizations such as Gates Foundation and many other organizations, including CDC and NIH and other organizations, may favor maintaining a certain level of vaccine manufacturing, meaning number of vaccines and different number of formulations that will be available worldwide, because every vaccine will not be suitable to be administered everywhere in the world. For example, Pfizer vaccine needed to be kept at -70 in African and Asian countries. Even in US, many of the counties may not have a -70 freezer chest available with them. So there will be need for different vaccine formulations at different places worldwide. Also, those different vaccine formulations needed to be kept or available at certain number dependent on the endemicity of this infection. So the pandemic will go away, come back, or this infection will remain as an endemic disease, meaning disease located at certain pockets in the world. So although it's hard to tell, but yes, vaccine numbers will be reduced dependent on the usage, but there will be definitely certain number of vaccine formulations at certain doses available or should be available throughout the world to combat this infection worldwide years to come. I hope that answers your comment or question.
Thank you, Dr. Mandal. Are there any other questions from any of our guests? I think your daughter is a guest. Does she want to try and stump her father?
Is she here? She told me she will be. Do you have any question for me, Rohini?
Oh, you got kudos from her.
Thank you. I appreciate it.
I think he did a pretty comprehensive job. Great talk, Dad.
Thank you.
All right. Well, thank you everyone for being with us, and we hope to see you in future Neighborhood Health Series. Thank you, Dr. Mandal, and thank you to Clark County Credit Union. Be well, stay safe, and have a great night.
Thank you very much. Thank you, everybody.
Bye.
Bye-bye.